Hello everyone, very good morning. Spondylolisthesis is often, proven to be the Achilles heel for minimally invasive spine surgeons in the sense that we often tend to reserve these cases for open surgery, knowing very well that these are the very cases who are going to need MIS surgery. One reason, anatomically, they are mostly at the deepest part of the lumbar spine, which requires maximum muscle dissection. From disease point of view, there is nothing happening in the center. All the diseases on the side, so again, they will benefit from MIS. Thirdly, look at the patient profile. Most of these are elderly or middle-aged ladies who are very obese. Again, they are the ones who are going to have to undergo the maximum dissection by open surgery. So what are the basic issues involved in managing these patients by MIS? How to look at the techniques, indications, all those things. We already know we're talking about fusion already, so I will not go into this in detail, but this is something everybody should go through. It's a very good paper for our secretary, Dr. Kulkarni, which takes into account the factors that are required to be taken into consideration while deciding whether the degenerative cases need fixation or not. There's an entire session on this at about 12 o'clock in this very hall, so I will not go in much detail. Whether to reduce or not to reduce. So we're talking about reduction. Yes, there is a lot of advantages of, or you can say, simplicity in doing in situ fixation, less blood loss, lesser chances of implant failure, also lesser chances of injury to the nerves. But reduction obviously gives you a better, you can say, more area for bony fusion. And also, most importantly, it helps to correct the spinal balance, which also helps in preventing progression at the other levels. So the advantages of reduction obviously outweigh the non-reduction, but again, there is still a debatable factor, debatable aspect. There's a lot of research yet to be done in that. But in general, we notice that as long as you're able to get your alignment back, the overall outcomes are better. So regarding the principles of spondy reduction, they remain the same, whether it's open surgery or MIS, talking about favorable positioning, adequate decompression, interbody distraction, as well as using screws for using bicortical and medially angulated screws for a good purchase. So talking about posterior reduction, posters and pelvis angulation is very important. It makes all the difference between easy surgery and a more difficult surgery. As you can see here, sometimes even with the help of translation reduction, we're able to build the body back, but we're not able to change the angulation. So positioning of the body makes all the difference. Compared to open surgery, it's important to go for a reverse Standelberg position because you're going through a port. So it'll save you a lot of pain in your neck if you're able to position this space more vertically. Also, the PUCAs, shivers and trials are actually bigger workhorses for this kind of reduction rather than pull on the screw itself, because it helps to increase the height and as the ligaments do the rest of the work. Just leave it there for a couple of minutes and you will notice translation getting is improving, even the angular deformity reducing gradually. So this can reduce up to 2 grades of listhesis. One can also use a temporary screw at the upper level. There are a lot of people who will go for a L1, L4 fixation in a patient who's got a L5 spondylolisthesis. And this is what you can do. Just use their extension of the screw as a reduction screw, pull it up, and then you can remove the screw at the L4. But we have overall realized that gradually we don't need L4 fixation at all in these cases. So cantilever forces, the implants are such that these sleeves act as reduction screws. You're able to tighten the S1 screw, and the other brittle body will reduce along with that. This has also been described the fulcrum lever method, though it's obviously more of a challenge in MIS, and also a challenge in patients who got a weaker bone quality. But this is something that can be done in cases there are some osteophytes where you need to free up the vertebral bodies. The instrumentation has definitely kept pace with the demands of the surgeons. This is a case where you have a Medtronic system, which is the reduction sleeve, and you can see how it pulls the screw up as you tighten the nut on the top. This is another illustration of the same. This is a system from Depu where you can use a rod reducer. I hope the videos work. Yeah. So here we're using a mechanical rod reducer. This definitely has places a lot of force on the screw itself, but the company says that there's little force on the screw, there's more force on the upper part. So this, we can also go for something like this, the cantilever method again being used. The lowest screw has been tightened, the knee has been tightened, extender has been added. And here you can see all the forces are not actually applying on the screw itself, but on the upper construct, this part. There have also been publications regarding spondylolisthesis reduction by MIS method. Dr. Deshpande has written an excellent publication. I have a couple of videos here. Yeah, this is what we call rocking technique, where they pull back on the upper vertebral body, and whatever is the best position, you tighten the screw there. There's a similar technique which has been described by the rocking technique by Park et al. This also, they use a similar method. Again, craniocaudal swinging is done with both the rods in place, and the fixation happens whenever the maximal reduction has taken place. So this is an example of a patient benefited from swinging technique. This is a case example from our own series, spondylolisthesis, pars fracture. This reduction was relatively easy because this is L4, L5, and you get a good straight access to the disc space. And this is a case of L5, S1. Again, the disc space is completely gone, but you can get a straight access. There is no difficulty in angulation. As you can see, the cages are not oversized. They are just appropriate to the upper level. This helps in reduction a lot. This is another case example, possibly grade 3 listhesis. This is intraoperative, so you're not able to get more reduction. Guide wires in place, distractors, screws being placed, rod being placed. This is the rod which has been tightened now. You place the spacer inside. Spacers help because they are slippery. They help in reduction of the listhesis compared to cages. So we normally tend to put the cage later. So if you see here, gradually it can pull the screw back and help you in reduction. So this is pre-op and post-op reduction in this case. But of course, this case we had to do a bilateral port access because we're putting the the screws also to the other side. This is another case example where a high-grade spondylolisthesis, and one can see this is the reduction post-operatively. This is another patient against pars defect. Often in these cases, we may have to go for a bilateral port because the scar is so much that you can't go across to the other side and do a decompression. This particular patient required a bilateral access, and so this we have two cages being placed here. It's still better than doing a midline surgery because you're still preventing a lot of damage to the midline structures which are removal of which is not going to benefit us anyway. So this is a biportal access with two cages, much like the PLIF. And this is a case where there was a high-grade listhesis, high-grade listhesis, but very severe osteoporosis. So these patients also definitely deserve and can be accessed by, improved by MIS method. This is all cement augmented screws being placed, and one does not need to then compromise on the forces required to reduce the vertebral body once the cementing has been done. This is a short video showing the system in place. The screw alignment, the sleeve has been inserted. These are the cement cannulas. You place them at the same level on both sides. Cement being prepared. Transferred to syringes. So this is the consistency of the cement. We get it immediately. This is a very, very safe consistency.
Sanjay, the time is...
Yeah. And this is the reduction, cementing augmentation. So in a nutshell, the key learnings have been that incision should be in line with the disc space rather than in line with the screws. Medial angulation of screws is important. Bicortical purchase of screws is also very, very important wherever possible. Distraction aids translational reduction, and also trials allow translation over smooth surface. And also the major limitations of MIS is possibility of screw pull-out, dysplastic pedicles, osteoporotic bones, but we have better PMM augmentation and dual-threaded screws as well as bicortical purchases to help us. So in conclusion, the decompression of nerves remains the primary goal, but obviously reduction is possible and should be attempted. 3D navigation, neuromonitoring help to minimize errors and also provide bicortical purchase. Thank you so much.